I found
Okay.
it too. And audience, I will start recording this session, so it's available later on the website. Welcome, everybody. My name is Harm Scherbier. Thank you for joining our webinar on the CMS Conditions of Participation Rule and what HSX with Audacious Inquiry is doing to make sure that your organization is covered. We have our technology partners from Audacious Inquiry joining us today to lead this webinar, and I will introduce them in just a minute. My name is Harm Scherbier. I'm the moderator for today's webinar. I'm the Chief Medical Information Officer at Healthshare Exchange, HSX. HSX is the Health Information Exchange organization in the Greater Philadelphia region, including southeastern Pennsylvania, parts of New Jersey, parts of Delaware. HSX is funded by its members, over 50 hospitals and health systems, more than 100 long-term care facilities, 10 health plans and payers, 16,000 plus physicians and providers, and we share data among providers for over 12 million patients in our region. This webinar today is the first in a series of HSX University webinars, a set of 4 webinars that are all focused on meeting the requirements of CMS and ONC, Medicare and ONC, the Office of the National Coordinator, regulating and promoting interoperability. And as, of course, we all still focus on managing and tracking COVID, it is now important to start paying attention to the CMS and ONC rules, which is why HSX is hosting this set of webinars. And hopefully you've received the sign up for this particular one today, but also for the subsequent one. They'll be 2 weeks from now, and every 2 weeks, same time, Tuesday at 1 o'clock. So I'm looking forward to having you join that series of webinars on this topic. So first, quick housekeeping items. We hope that all your lines will be on mute. If you do have a question or a comment, please type it in the question window. There's a question window in your panel, and both Fatima and myself see the question, so please feel free to type in a question. I will be able to see those. Like I said, this will be a recorded session, and the link to the recording will be shared after the presentation. As many of you know, Audacious Inquiry has worked with HSX to develop the Encounter Notification Service back in 2012. It's now supporting many of our members through Encounter Notification and Smart Alerts. As a matter of fact, in the COVID period, we worked with the AI team to create a COVID-specific alert that would help our providers know if any of their patients was seen with a COVID-related encounter. So that's been very, very helpful to be aware of these cases as soon as possible. It is my honor today to introduce the presenters from Audacious Inquiry. Robhorst, he's the Senior Vice President of Partner Engagement at Audacious Inquiry, AI, and leads AI's Encounter Notification line of business. Rob has led the organization's support of HSX since 2015. Also, Corey Mertz, he is the Senior Director of Health IT Policy for Audacious Inquiry. He has led a wide range of federal health policy and interoperability consulting projects for AI's customers. He used to work for the ONC, Office of the National Coordinator, for 6 years, where he helped launch and execute the HITECH Act and was deeply involved in the State Health Information Exchange Program. Also joining us today is Dr. Samit Desai, AI's Chief Medical Officer, who offers his clinical perspective in support of value-added product enhancements and serves as an advisor to Audacious Inquiry. Prior to AI, Dr. Desai was the CMIO, Chief Medical Information Officer at St. Agnes Ascension Health. He is boarded in emergency medicine and clinical informatics. He attended Drexel School of Medicine and then trained at Johns Hopkins Hospital. After all those intros, I would like to turn it over to Corey, who will start the webinar and tell us about the CMS rules on interoperability. Corey, please.
Great, thank you. And good afternoon, everybody. As was mentioned, right, CMS finalized a rule earlier this year establishing a new condition of participation in the Medicare and Medicaid programs, requiring hospitals, psychiatric hospitals, and critical access hospitals to send electronic notifications to certain community providers when a patient shows up at the hospital. And this requirement is going to go into effect in May of 2021. And will be incorporated as part of the Medicare hospital survey process. So this is going to be another thing to add to your existing compliance program for the survey and certification process. Make sure you establish policies and procedures to document and demonstrate to the auditors when they're on site that you have complied with the program. So the next slide, we'll dive into the details of what the new requirements are. So CMS is requiring hospitals to make a reasonable effort to send notifications when these kind of conditions happen that we're going to talk through here. So when a patient has an inpatient, emergency department, or observation, admission, discharge, or transfer, those are the kind of conditions in which CMS is expecting a hospital to generate a notification, and the kind of organizations the hospital needs to send it to are next, right? So the recipients from CMS's perspective, they outline 3 categories. The first is a patient's established primary care provider or primary care practice. The second is the patient's established post-acute care providers and suppliers. So, a simple example here, right, would be if the patient is admitted from a skilled nursing facility, the expectation would be the hospital is able to generate notifications back to that skilled nursing facilities. And the third bucket, which was net new in the final rule, CMS established the concept that a patient should be able to assert a provider that they want notifications to go to, and this would be any provider that the patient says is primarily responsible for his or her care. So again, keep in mind this is not limited to just primary care providers or post-acute care providers. So it could be a cardiologist or any other specialty provider that the patient says, hey, this is my primary provider and I want notifications to go to them. CMS has established this reasonable effort expectation that a hospital is going to try to figure out how to route a notification to that provider as requested by the patient. So for what reasons do you have to send notifications? So it's got to be under treatment, care coordination, or quality improvement. So as you think about this condition of participation, really it's focused on those purposes for who and when you have to send notifications. Certainly keep in mind there's a lot of other regulatory requirements going into place during this timeline as well. So as you think about your information blocking compliance obligations, certainly broader than what the kind of CMS condition of participation requires for as far as who you might need to send notifications to. So just something to keep in mind as you're kind of developing your compliance program here. So for who this covers, it's all patients, right? So keep in mind, this is not just Medicare and Medicaid patients, it's all patients that kind of hit the triggering events that are admitted to the hospital. So not just Medicare and Medicaid. As you think about the data that has to go in these notifications, CMS sets a pretty kind of, outlines 3 things that have to be in there, right? So it's the name of the patient, the name of the treating provider, and the name of the sending institution. And those are the only things that CMS requires to be in the notifications to comply with the condition of participation. As far as content and transport standards, CMS is really agnostic on that, leaves it open to the hospital to decide what standards to use. And 2 other just important things to keep in mind. CMS explicitly acknowledges the concept of hospitals using an intermediary like HSX to provide the notifications on their behalf, right? So a hospital can send a notification to an organization like HSX, and then HSX can do the work of figuring out who the subscribers are that want the notification on that patient, or the kind of other steps they take to figure out where that notification should be sent. CMS, explicitly talks through all that and says that is a great model to follow. And similarly, the kind of subscription-based model, right, where a provider where a patient provider says these are the patients I'm interested in. CMS acknowledges that model is out there and it's something that is in compliance with the requirements. The last thing to just note is you think about your requirements, right? If a patient expresses a preference, right? So if they kind of leverage their HIPAA right to say, hey, I don't want my data exchanged, that's okay from a CMS COP compliance perspective, right? If a patient is expressing a privacy preference to not have a notification go, that's fine. You're still meeting your obligations. The last thing to keep in mind as you think about how this is going to get enforced, right? This is going to be under the survey and certification process, as we talked about, right? So it's going to be enforced through that same process, the kind of what you've seen today. And CMS generally buckets this one under the kind of medical records conditions of participation. So in the rule, they talk about, hey, when we go on site to enforce this, we'll follow a lot of the similar processes that we have for other conditions of participation like this. So we'll look at your policies and procedures. We'll look at your organizational structure. We'll do a review of sample records, medical records, while we're on site to determine if notifications were generated as they should have been. The 2 other things to keep in mind, CMS has committed to providing guidance to the auditors or to the surveyors that will be issued prior to the start of this requirement in May of next year. That guidance has not come out yet. it's certainly something we'll be watching for to see how they kind of implement that. Yeah, okay, next slide. Just one more before I turn it over. So again, with this, right, keep in mind the kind of left-hand view is what you'd have to do if you were doing this on your own, right? A hospital is going to be expected to make all these connections with community providers and be able to send notifications as required by the condition of participation. On the right-hand side, you have HSX as your intermediary, kind of simplifying for this, right? You provide them the feed of your ADTs, and they figure out where to distribute it. So again, this is really kind of very much in alignment with the intermediary model that CMS outlines in the rule. So with that, I will turn it over to Dr. Desai to talk through the notification service at HSX.
Thanks, Corey. It's a pretty simple diagram here, but just to remind you all, I think most of you all are familiar with how ENShare works, but on the left-hand side, you see hospital. That really represents the many different data sources that over the years HSX has connected to the ENShare platform. And this is where we source our ADT data, that admission, discharge, transfer, registration data. When it comes into HSX, we then perform some patient matching, which is a really critical element of this workflow and solution. And then we look up all the different subscribing organizations that may have subscribed to that patient. And this is a key point to make. While the rule is somewhat general in referencing providers, explicitly mentioning primary care and the SNFs, as Corey mentioned, we know that with ENShare, there is a vast array of subscribing organizations, from primary care docs to home health, to hospice, to ACOs. And it's just another important facet of the HSX ENShare implementation that's worth noting, that this isn't a narrow compliance solution, that there's a lot of impact happening in the greater Philadelphia area that's been happening, and we see this rule creating further impact. Next slide. Just a reminder on the flexibility of notification delivery. A simple interpretation of the rule, a simple implementation of the rule across the country is largely going to result in primary care docs and providers getting almost spammed in their direct email inboxes, which will be an interesting thing to witness and what will come of that. But we know that ENShare has long supported many different means of alerting subscribers. It's one of its key features, and we understand all of your organizations that are on the subscriber side are different, and you have set up different workflows. And that ranges from ENShare's web portal that's easily accessible through your browser to email alerts. We still know that sending a CSV or Excel file via secure email is an important way in which organizations get work done and communicate internally. And we support more sophisticated standards outbound. Many of your organizations have chosen for us to integrate with their EMRs. And so for those of you familiar, HL7 2.x, we even support FHIR, one of the emerging standards for those organizations that request it. This is a key piece to remember, which is we know, ENShare knows how providers want to be alerted, and we'll continue to alert them for traditional alerting, but when patients assert that they want Dr. Mertz to be alerted, we can take those preferences and alert outbound. Next slide. As Corey stated, CMS has made it very clear that an intermediary, HSX in this instance, and its ENShare platform, can be used to comply with the rule. And so we're very well positioned to do that for you all. There are two key elements that we'll be supporting in a new fashion here. One is this notion of supporting patient assertion. There's a little bit of irony. Some of the earliest types of encounter notification solutions solely based alerting when a patient, during the time of registration, said who their doctor was. And it just turned out that that was an inefficient and not sufficiently robust process. Either patients didn't know who their doctor was, or the registrar didn't record it correctly. You couldn't match the provider. And so to really do care coordination well at scale in a region, we needed to take this panel-based approach, which has proven to be so successful. But that being said, we do want to be patient-centered. We know that's a core strategy of CMS. And so moving forward, when your hospitals adopt new policies and procedures, and they ask patients whether that patient wants their primary care or other doctor alerted, EnShare will take the provider's name that's coming through that ADT message, bump that up against a national directory of direct addresses, that secure email form, and send it on over. This is a key new feature. We're excited to offer it, and it will live alongside those traditional panel-based forms of alerting. Next question. Oh, sorry, next
slide.
Next slide. Forgive me. Yep.
No, we'll get there.
The other key feature that EnShare will make available to participating organizations is a compliance report. Corey referenced the survey and cert process, wherein a CMS auditor will show up as they do to check for compliance with conditions of certification. And we really want to be able to provide you all with a report that you can then hand to that CMS auditor and make this as easy as possible. Some of the key elements of the report will include, sort of line by line, Corey mentioned the different encounter types for which we need to alert outbound, that ER visit, that inpatient admission, inpatient discharge. And for every one of those alert types, we will provide a numerator of outbound alerts for each of those events. In addition, we will provide the mechanism of alerting, whether that's the more traditional panel-based outbound alerting or when a patient asserts that they want Dr. Mertz to be alerted, we will denote that. So that's very clear to the auditor that you support patient assertion, that you're meeting the alerting for every one of these alert types, including observation stay, and make this as clear as day. There are some additional elements that we are considering adding in, like letting your organization know who the top primary care docs are that are being alerted and or that are being referred into your network and whether we are alerting them. So you can perform the kind of outreach that closes care gaps, which is the essence of the EnShare solution, but also the rule. And then the final point here is Corey mentioned that CMS has not yet provided guidance. They soon will. We will be on top of that. That's part of the value add that we offer to you all. And we will amend the report accordingly so that, again, it becomes an easy affair when you have your compliance team work with IT to meet the need. Great. And then the final point, which we've made throughout and continue to make, is you will be compliant by the time May 2021 rolls around. But this is more than just compliance. And today, a ton of value is being, a ton of real clinical impact is resulting from this solution, care coordination at scale. We just want to remind you about the larger network of providers that are being alerted today. And then a few other things to note. The data quality here matters. HSX has long valued very high levels of data quality. So when you think about both the rule, but also all the data you need to be impactful, the feeds as they exist today are very high quality and will continue to be of value to subscribing organizations. Next slide. One of the final points we want to make is when AI and HSX support you all in May, we do so through the product. And so you'll see there on the left all the technical checkboxes that EnShare will meet for you. But this is more than just technology. We know that you will need, we all, as we both monitor ONC and CMS, need to stay on top of the CMS guidance, and that we should make product documentation available to you all so that it's clear as day what you need to do, whether it relates to the product itself or guidance as it relates to policies and procedures that may need to change at registration. And so you'll see on the left some of the things we've mentioned, how the technology will support you. On the right, there are no gaps, even though it looks like that. It's really just to illustrate that, for example, alerting on observation stay, you may not do right now. We are able to provide you guidance about where in the ADT, where in that registration feed it's optimal to make that information available. Next slide, Rob. More so to the point, you'll see on all the way on the left-hand side, other facets of the rule, the privacy preferences that Corey mentioned, reporting that we've talked about. And this is another place in which not only are we providing technology, but we're providing a lot of documentation and collateral to you all so that you feel ready. Next slide. I think, Rob, are you taking this one or shall I?
Yeah, I'll take this. So good afternoon, everyone. My name is Robhorst. I've worked alongside HSX for a number of years. And we want to include these a couple slides at the end here to really talk about what is next. Now that you've learned this from, learned about the regulations from Corey, you've learned about the underlying technology from Summit. What do you need to do if you're already sending data to HSX? As Summit mentioned, HSX's data quality has always been very high. We will be working with you, and HSX will be working with the data sending organizations, which is predominantly the hospitals, to make sure that you are including a provider NPI, attending physicians, and other types of events such as observation stay to HSX. When you send those in the ADT, that is going to allow the new features that we're introducing, such as the self-assertion that Summit mentioned, to really operate efficiently. So just to tie it back to the ADT, if we see an NPI in that ADT message, we're going to be able to match that up, find a direct address for that provider, and forward that notification on. Summit also mentioned, the sort of ideal workflows. The ideal workflow is to impanel your patients optimally, and we certainly encourage practices to reach out to HSX and set up a subscription so that they can receive alerts in a more elegant type of workflow that really meets their needs. But for the self-assertion, that's how it's going to work. HSX will also be working with hospitals to provide you sort of an analysis of what your feeds look like and what data might need to be included in the ADT that might not already be coming over. Finally, if you're a subscriber, what do you need to do? You will just really continue to receive alerts. If you're already subscribing, you won't see a material change. However, if you do wish to get the patient asserted alerts through your existing workflows, you would need to include the NPI information in your panel and attribute the patients in the panel to a provider NPI. And if we have that in there, then we can direct them to that provider through your existing workflows. So I'll say this just one more time. I mean, there are obviously many organizations that are already subscribing. There's very insignificant lift on your part. If you're on the call today and you're not subscribing, we would certainly encourage you to reach out to the HSX team and get onboarded. And if you're a hospital that's on the line and you know of employed or affiliated practices that would benefit from receiving your alerts, I would encourage you to do the same. So let those practices know that the EN Share service exists, and connect those folks with HSX, and they'd be more than happy to get you all moving and get them connected so they can receive the hospital alerts. So at this point, Harm, we'd be happy to open it up to questions from the audience.
So yeah, thank you, Rob, Sumit, Corey, for the overview. Corey starting with the policy, Sumit with technology, Rob focused on implementation. Anybody in the audience, if you have a question, please type it into the question box on your right-hand panel. In the meantime, there's one question that came up earlier. I'm not sure if it's in the context of this conversation today, but the question is, what does HSX do to the payer-based requirements for interoperability for CMS and ONC? And I don't know that's in the scope for today's conversation, but Rob, is there any comment that you can give about the payer side of or Corey, the payer side of the CMS regulations and how HSX can help comply to those requirements?
I'm going to need to kick that over to my colleagues here. Corey, I'm not sure if you guys have thoughts on the payer impact here.
I can definitely talk about the requirements. I'm not that familiar with what HSX might be doing in that space. But as you think about the CMS rule, there were a couple of requirements on payer organizations. So one was for Medicaid, Medicare Advantage, and CHIP and MCOs to provide patients access to their data. Again, kind of on a similar line to how Blue Button 2.0 works, using Fire-based APIs so patients can make some, get access to their data, direct it to certain third-party apps of their choosing. So CMS is putting that requirement in place on Medicaid agencies, MCOs, and Medicare Advantage plans. And then the other component to keep in mind is that CMS has established a requirement for Medicare Advantage plan and MCOs to do some care coordination. So when a patient switches plans, they'd be able to request their old plan, send data to their new plan, and it's much more of a clinical data set that kind of transition is focused on. So it's a quick summary of some of the big ones.
Thank you, Corey. And while that may not be exactly in the scope of encounter notification, those are, and I think we'll deal with some of those requirements in our upcoming sessions of these webinars in HSX University. Another question that just came up from Joel Kahn. Rob, I gave it to you. Can you see it on your screen, or shall I read it to you?
If you could read them out loud, that would be great.
So Joel's question is, what hospital providers need to be included in the fee to HSX to meet the CMS requirements? For example, consultants.
Yeah, Simon, you want to take that? I mean, I believe it's really PCP as well as attending. Is that correct?
Yeah. For the requirement, as far as what information to include, CMS specifies the attending provider. So you don't need to provide many of the other physician types that may be consulting within a given hospital stay. On the outbound side, meaning who we alert, it's really whomever the patient would want us to alert on the provider side. That's, we typically say, primary care doctors. And so as it relates to the feed, we will need to know who it is that we need to alert. So there's the attending for communicating that information in the alert itself, and then the provider PCP often as far as who to communicate with, who to alert.
Another question from John Potts from Mainline Health. Is it enough to subscribe to ENShare encounter notification to be compliant?
If I'm understanding correctly, if you're a hospital organization that participates with CMS, is it enough to, that's what I hear in that question.
Okay, go for it.
And the answer would be no. As a hospital, if you're already participating in sending data, you're good. If you're not, you do not have a system in place in which you may alert primary care docs and other provider types based on patient preference, then it would not be enough to be a subscriber of alerts and to receive alerts. If I'm not answering that right, please clarify your question.
Samit, let me try to summarize that. So the requirement on the hospital is to send the notifications. The hospital is not required. The hospital is not required to make sure that the PCPs actually receive it.
Right. This falls under that reasonable effort provision that Corey referenced. And it would be a reasonable effort to participate with HSX and the ENShare software to alert these providers, because they can subscribe with ease, or of course, if they have a direct address, that's another means by which we'll alert them.
Do you expect hospitals, in addition to sending out these notifications through HSX or through any other way, preferably through HSX, do you also expect those hospitals to work with their either employed primary care physicians or affiliated primary care physicians or specialists to encourage or to enable or to help them in receiving these alerts? And what do you think the role should be for a hospital in that to help on the receiving side, if any?
Yeah, maybe Corey, if you can take that and I can follow on, maybe if you do from how you think CMS would interpret that.
Yeah, sure. So, again, I think this is going to get back to the reasonable effort definition, right? And I think I think you have a service available for providers to subscribe to if they wish to receive alerts. And in those situations where there's a patient asserted provider that it should go to, again, I think stating that using the Direct Trust Directory, which I think is widely recognized as the most comprehensive directory of direct addresses available nationwide, that to us feels like it hits that bar of reasonable effort, right? The CMS in the rule, it's not like expecting you to have a Swiss Army knife and every last approach needs to be tried with a provider organization to prove you are in compliance with the rule. You need to set a reasonable bar and have a good justification for it. And if you do that and you follow what you say you're going to do, you're okay. Is the way CMS is trying to outline it.
Yeah, the other thing you might mention is, well, I think on the subscriber side, I guess the question was how can hospitals sort of help support that? I think really more than anything, it's probably awareness. Hey, you're going to want to let the groups that your patients are going out and seeing, sort of in the ambulatory world, are going to want to receive those alerts. And if they're not already receiving them through ENShare, I think it's just a matter of encouraging them to get signed up with the ENShare. And then from there, that's something that HSX is going to largely handle for you. There's a whole variety of different ways to receive those alerts that really meet the workflow that the practice might want. So it's hopefully that answers the question. I think it's really just it's an outreach role, it's an encouragement role, it's an awareness role to get connected with HSX.
Yep. A similar question, I think heading in the same direction, but let's address it here from Sharon Gage-Morris from Temple University. For a PCP or specialist, that's not a subscriber, but the hospital is a subscriber and sends ADT. Will that PCP receive the message? In other words,
So a lot of this has to deal with how if Temple is indeed subscribing to ENShare.
They are.
And
as a sender.
That physician's patients are being care managed, being followed up with, then organizations can do count as a recipient, and that, in our view, would be acceptable, an acceptable set of workflows. It isn't that the doctor, him or herself, needs to be alerted. We know that these workflows may not go directly to that physician. I don't know, Rob, if you want to take that a little differently, but I think the short answer would be our interpretation is that is acceptable because it meets the intent of the rule, and that provider is being covered by the organization and their care management workflows.
Yeah, I still think there's tremendous benefit in working with HSX in a scenario like that, because that employed Temple practice is going to want to be alerted not just when that patient is hospitalized at Temple, but when that patient receives a hospitalization anywhere in the HSX sort of catchment area, and that's where that benefit's really going to come in. Right. So I think in that scenario, I would still encourage the Temple practice to work with HSX to receive those alerts back into their workflow.
So that's definitely part of the answer. Let's make so it would be great for health systems to make sure that their high volume practices are all subscribing to ANS and are part of the ENS subscriptions. There may be cases where a PCP or a specialist is far away or low volume. In that case, I believe a direct message would also reach that PCP or so that is even a better approach for outside of your immediate network, where it's less likely that they would subscribe to HSX encounter notification. Can you speak to that? Would direct message be the next level of connectivity to that practice?
That's right. The directory that we would access is not state bound, and if a patient says Dr. Mertz is my doctor and Dr. Mertz is some few hundred miles away, so long as his direct address is in that directory, we would be able to alert him.
Good. Thank you. Question from Sherry Brummans. How about mental health and behavioral health providers? How many participating?
That's a great question.
Health providers, and how would this exchange be used for that group of providers?
So ENShare now, and Harm, you have more on the ground in terms of HSX implementation, but ENShare now does allow behavioral health providers, substance use disorder providers to subscribe to ENS and receive alerts. And we've implemented that in a way that is compliant with the federal regulation 42 CFR Part 2 that I'm sure many of you are aware of, that makes clear that you can't share that relationship, can't share the fact that patient is being seen by a substance use disorder provider. And so in EN Share, we have blocked that information from being made available to the broader healthcare community, unless the patient consents, which is a different ballgame. And so they are participating now. Insofar as if a patient says, I want my substance use disorder provider alerted, and they give that name, and that's a patient assertion, I would assume that that would work. It's sort of we can sort of take that back and be more clear about it, but we would technically be able to alert that provider with the new features we're bringing forward.
How about if you flip that around? How about if the inpatient scenario was for psychiatry, behavioral health, substance abuse? Would
that's right.
Would that then send a notification to their regular primary care provider?
Yeah, so a good example is an ER visit. In ER visits, there is enough sort of legal opinion that when patients show up to the ER for a mental health disorder or substance use disorder, that because that ER does not hold itself out to be a substance use disorder facility, it is reasonable to share that visit with the healthcare community through a platform like ENS. So that's allowed and is in compliance with the rule, the federal rule. For stays in the inpatient ward where it's very clear that the patient was there for a substance use disorder, then we would not alert outbound, and we do not do that today in the currently operating EN Share. Nothing would change about that dynamic as it relates to the new CMS rule.
And does CMS actually carve that out specifically in their ruling, that this requirement is not valid for behavioral health? Corey, do you know that?
Yeah, so that's where I was getting at the patient preference, right? So if like with 42 CFR Part 2, right, authorization, opt-in authorization is ultimately required to send that data to another organization. If the hospital does not have that authorization, they could not send the notification.
Mm-hmm. Yeah,
and that would be in compliance with the rule.
Question from Cheryl Roche Alexander. I believe this rule also pertains to patient access to their information. How would this work with HSX? I think I'm going to answer that myself because I don't think that is specific to encounter notification. Encounter notification is very much a provider-to-provider transaction, and that's the scope for today's conversation. I think it is true that the ONC and CMS rules include patient access to their information primarily. Corey, I'm going to ask you to help here soon. Primarily, access to their health plan information. Patients in many cases in most cases already have access to their clinical information, and typically that's done directly by the provider. So HSX is not necessarily in the loop where it goes from provider to the patient. That is mostly handled by the provider directly. Sumit or Corey, can you add to that concept?
Yeah, so as you think about the CMS rule, you're right. It's really focused on particularly payer organizations providing patients access to their data. As you think about the kind of obligations on provider organizations, really a lot of that has already been in place, right? So through the Promoting Interoperability program and through the MIPS program, the requirements there have been longstanding for patient access.
Yeah.
What happened in this most recent, and this might be getting too into the weeds, but I'm gonna go there. What happened in this most recent cycle of rulemaking was ONC changed the standards that you had to use to provide that patient access, right? And moved to FHIR. Before, it was really functional-based certification requirements. Now they've got specific named SDO-approved standards that your vendor organization needs to use, get certified to, and then you need to deploy in the field in the future to actually provide patients access to their data.
Yeah. I have a question for Sumit. Earlier, you explained in one of your slides how there are various ways to deliver encounter notification to practices, and from FHIR to spreadsheet to CSV file to portal. In our current environment, what do you see as the most common way that providers do this today? And from an AI perspective, what's your preferred direction? Where do you think people should be heading on delivering these messages?
Great question. I don't know if I can answer it perfectly. We see all of these formats being used at scale. CSV, again, is still a very common method because of the way care management functions are supported. And so we really had a deferential approach here because we know every organization is different and has different needs. As far as preference, we built EN Share purposefully to manage these alerts, to be able to denote status for TCM use cases in particular, and we've seen a lot of good uptake. And so, to the extent that we can continue to innovate and provide value through the web portal, it's useful for users to go, and we have a lot more agency and control and can innovate in a number of ways through the portal. So we don't really have a preference, but we would certainly encourage use of EN Share because of those kinds of things.
Yeah, I mean, we really focus on workflow primarily. I mean, I would almost turn the question around and ask the practice, how do you want to receive them so that it's integrated into your workflow in the best possible way? We have implementations where we push it directly into the EMR, into like a work list, and the alerts, look just like data that might be natively there in the EMR. That's a great use case. The EN Share web-based platform is heavily used for HSX subscribers as well. So are direct messages, direct secure messages, and just sort of sending that summary CSV file. So it really is flexible. I think you just need to look at what's best for your organization.
Good.
Harm, any other questions?
Those are all the questions on the list. If there's any additional questions, please enter them in, and we will address them as soon as possible. In the meantime, while we're waiting for additional questions, let me see if I could summarize very briefly what this topic is all about. If you're a health system or hospital and you're a member of HSX, you're basically already covered and ready for this particular CMS conditions of participation. As long as you're sending ADT information, which allows us to use those for encounter notification. So that's good. At the same time,
let me just, if I can add on.
Did I mishandle that slide?
You're absolutely right. You're absolutely right there, Harm. We do want to encourage the addition of provider NPI, because that's going to really make that patient assertion use case light up, and that's going to be important.
At your provider API. And also, I remember correctly, and this was a question that came up earlier, but I'm glad we're going over this again. Observation patients. Today, we do not do encounter notification for observation patients. It is our intention to do that, but it does require for hospitals to send us that encounter transaction, correct?
Yes, yes, that's right, Harm. Right now, ENS, we have built-in logic because, as you know, the platform takes in feeds from 800 plus hospitals across the country. So there are a certain number of ways in which we know observation status is shared with the big EMRs. And so we'll be able to, once we turn that functionality live, and share, get some percentage of that. But many hospitals simply don't share it. And this is where we will provide guidance to what segment and field within the ADT would be optimal.
Yeah.
And we know that every EMR can support this, so hopefully not too burdensome a task.
Good. So that's on the hospital side. If you're a health system with many practices, please encourage all of them to subscribe to encounter notification and have them pick the delivery method that is best for their practice and for their workflow. And you've heard from the team here that there's many ways to get those encounters delivered to those notifications delivered to your team. If you're a practice and you don't yet receive these encounter notifications, please contact us and subscribe to encounter notifications so that you start receiving these messages in. And finally, I think if you're a health system that has a lot of affiliated practices, and I think many health systems in the Philadelphia area are, please consider whether you can help your surrounding practices to enable and turn on their encounter notification by subscribing to HSX encounter notification so that they will receive your messages. I mean, it's only as good. If you're sending but they're not receiving, it still doesn't make a lot of difference to the patient. You may be in compliance with the rule, but you may not be helping the healthcare in the region. So I think the role for us as healthcare providers is to have it turned on for our own site, but also make sure that our recipients, as much as possible, have their encounter notification turned on. And please reach out to us to if you need help or if we can, in some ways, assist you with that. There is one more question.
Oh, great.
You want one more question? Do you have time for one more question?
Let's do it.
From Sherry Brummans, the question is, are there current plans, I'm not sure if it's your question, but let's try. Are there current plans for connecting to other HIEs throughout the nation? And let's answer that question, not so much connecting everything to everything, but let's specifically to encounter notification. How can HSX and AI either deliver encounter notifications to other HIEs or receive encounter notifications from other HIEs? How does that work?
Yeah, I'll take a stab at that. So HSX is actually already doing that to a fair degree. I mean, so HSX participates already with the Pennsylvania eHealth Collaborative and shares ADTs with that network, and also receives ADTs from that network for patients that are hospitalized. So for example, HSX might get an emergency admit from a hospital in the Pittsburgh area, as one example. HSX also works with NJHIN, which is the New Jersey Health Information Network, and provides a similar ADT sharing capability there, as well as with DIN, which is the Delaware Health Information Network. So there is a good bit of regional sharing going on already within this network, and that should really help just enhance this, because if your patients are having hospitalizations in surrounding states, chances are you're going to get an alert for those as well.
So when I have a Verizon telephone, I can still call somebody who has a Sprint phone, right? Those networks are connected to each other.
Yeah, although Sprint really is, it's not a great network, but I've never had any luck with it anyway. I'm just kidding. So
it was just an example. T-Mobile, whatever.
My closing thought here, if I may, is that really the conditions of participation really explicitly call out intermediaries, and HSX is the intermediary in your region. And I think that one of the biggest takeaways is there's a little bit of work to get that additional data sent in the ADT, but other than that, hospitals should not have to go out and make new purchases of new systems and things like that. They should really be able to rely on the feed that they're already sending to HSX, and HSX and AI through our EM Share solution will deliver it the last mile. We'll provide you with an audit report back to tell you where your ADTs went, and we're really hoping that this is a pretty simple process for you. So
great, good.
Thank you.
With that, I'd like to thank Rob, Sumit, Corey, thank you for your explanation. Thank you for bringing us up to date on encounter notification and on the CMS requirements coming up. We have till May next year, but I think we should get this going sooner rather than later, because it's also good business and we should be doing this anyway. Encourage again everybody on the audience to contact HSX if there's any way in which we can help you, your organization, be part of this network. We would love that. And I would like to welcome you to the next session of HSX University, which will be Tuesday, 2 weeks from now, 1 o'clock. You will be getting the sign up and registration information in your email, and I would love to see many of you at that session also. Rob, Sumit, Corey, thank you very, very much. It was a great conversation today. Thank you.
Great to be with you.
Thanks, Art. Yep, take care, everyone.
Thank you.